Well, good morning, everyone, and thank you so much for joining us today at the Houston Methodist Grand Rounds. My name is Mohammed Shamsi Pasha, and I'm a multimodality imager here. A few housekeeping issues before we introduce our speaker. Please use the microphone to ask questions because we are broadcasting this lecture live to our worldwide audience via Vimeo and YouTube. And the recording is always available for viewing after the presentation. Consider subscribing to our YouTube channel to get notifications when the videos are added. And for our online viewers, if you'd like to submit a question, please text DeBakey, DEBAKEY, to 37607. Please be on the lookout for our next conferences. Are going to be the Book Out Center Annual Symposium, October the 7th to the 9th, and the Multimodality Cardiovascular Imaging for the Physician or the clinician, which is actually happening this weekend at our research institute. There is an open aortic training also held between October the 24th and October the 25th. It really gives me a great pleasure and a distinct honor to introduce our speaker today, Dr. J. O., who truly does not need an introduction. Dr. O is the Samsung Professor in the Department of Cardiovascular Medicine at Mayo Clinic in Rochester, Minnesota. He's also the director of the Echo Core Lab and the director of the Pericardial Disease Clinic, where he has actually spent considerable amount of time and research there. So he's nationally known and internationally known for his research interest in echo, hemodynamics, diastolic function, valvular, and pericardial disease, having authored over 500 manuscripts and the latest 4th edition of the Echo Manual, which I'm sure most of our cardiology former and current graduates actually have come across. Dr. O has actually received many honors, including the Lifetime Achievement Award from the European Society of Cardiology Myocardial Pericardial Working Group, along with the Lifetime Achievement Award from the American Society of Echo. He has been the core lab for over 30 trials at Mayo Clinic and also has proudly mentored tons of physicians throughout the years since he's been at Mayo since 1985. Dr. O is currently the president of the Asian Pacific Association of Echo, and he always gives credits to his mentors, Dr. Liv Hatley, Jamil Tajik, and James Seward. Today, he's going to be talking to us about constrictive pericarditis, curable therapy, curable HFpEF by imaging, and optimal therapy. Dr. O, thank you so much for coming in, and looking forward to your talk.
Thank you very much, Dr. Pasha, and everyone. Good morning, and really appreciate the introduction. And when I look at the Houston Methodist Hospital and Mayo Clinic, I think we really came sort of similar path, especially for echocardiography. I'm sure other specialties too, and Dr. Zavi. And I think we had mentor like Dr. Quinones, and we have Seward and Tajik for us. And then our generation. Then after that, I'm sure you have Steve Little and Sharif Nagwe, and then Dr. Pasha, others doing all the structural heart disease and diastolic function and others. So I really feel very comfortable coming here and feel like our family members. And I think the echocardiography really has been a bridge to great patient care and a lot of great investigation, but also a bridge to a great friendship. So I really appreciate the invitation and being with you today. So I'll talk to you. This is sort of my lifetime passion, and I want to share with you these a few disclosures I have, but I just want to today, we'll talk to you about the sort of multimodality imaging, especially with special emphasis on echocardiography, how to recognize and identify constriction and separate it from myocardial disease. And then share with you some illustrative cases to highlight the not just typical cases, but now unusual cases that we see. And then understand the treatment strategies based on imaging and then our clinical evaluation in patients with a constriction. Before I go further, I just want to start with mentors and mentees. I think this is so important. And Dr. Pasha mentioned Liv Hadley, Tajik, and Sword, and the three individuals been really the mentor for my early career. And especially I want to talk a little bit about Liv Hadley, because she was the one who really developed the concept of constriction, all the hemodynamic stuff from Doppler echocardiography, pioneer in Doppler echocardiogram. And then with their teaching, and then we have an opportunity to teach others now, so many others, to carry what we've been doing with echocardiogram and hemodynamics and cardiology investigations. So she was the first with the Chris Appleton when she went to Stanford in mid-1980s to really show the ability of echocardiography to demonstrate characteristic hemodynamics she did all of the valve disease. I know Dr. Zabian, we did the continuity equation validation when they came out early 1980s, but she came and now she was into diastolic function evaluation, and then luckily she had Chris Appleton there, and she was a fellow at that time at Stanford, and she showed with these 18 patients, a small number, but the most of important observations in cardiology, especially hemodynamics, all comes from 10 to 15 patients. And she showed that in patients with a constriction has this characteristic hemodynamics of dissociation between intracardiac and intrathoracic pressure, meaning because of thick pericardial layer, that usual transmission of the intrathoracic pressure change with the respiration is not fully transmitted to the heart. So luckily, Liv Hadley and Dr. Tajik got to know from one of the meetings, and I hear they were in Russia together, and then he invited her to visiting professorship at Mayo Clinic in 1987, 88, and then I became the staff right before that, and then we got to work with her. And we are very excited, and this is actually the first simultaneous Doppler and hemodynamics of patient with a constrictive pericarditis. Dr. Nishimura was doing hemodynamics, and I was doing cardiac catheterization at that time, showing this dissociation of pressures in the lung and also intracardiac pressures. I showed you thick pericardial layer. Normally, you breathe in 3 to 5 millimeter mercury pressure change drop, and then that fully transmitted to the heart. But with the thickened layers, because if you look at this pressure tracing with inspiration, wedge pressure reflecting the intrathoracic pressure falls 4 or 5 millimeter mercury, but intracardiac pressure here with LV diastolic pressure here does not change much. So a result of that, driving pressure gradient to the left side chamber decreases with inspiration, and then go back to expiration, then increases, right? So that simultaneous mitral inflow velocity reflect the decreased filling with inspiration here and increased filling with expiration here. This is simultaneous. So that's why we use respiratory variation of the mitral inflow velocity as one of the characteristic Doppler finding of patients with a constrictive pericarditis at that time. So let me just show you one more time, same physiology, hemodynamics, and also we're going to add one more characteristic of constriction, that is the interventricular dependence. Because of thick layer, with a change in one side of the heart volume, it'll make a change in the other side. So if you have more filling to the left, you'll have less filling to the right side chamber, and vice versa. That does not happen with the normal pericardium, but with a thick pericardial layer, we have significant interventricular dependence. So we have these two characteristic hemodynamics. I'm going to show you with this animation we created a long time ago, that here is the blue intracardiac pressures, and purple is the intrathoracic pressure using the pulmonary wedge pressure. So with the inspiration, you have the decrease in intrathoracic pressures with no significant change in the intracardiac pressure there, the decreased filling to the left that allows septum deviating to the left side chamber and more filling to the right, and then that makes the pulmonary vein Doppler velocity and mitral inflow velocity decreases with inspiration, and then tricuspid inflow velocity will increase, and hepatic vein Doppler forward flow velocity will increase with no significant reversals. With the expiration, the complete opposite, because with the increase in intrathoracic pressure, there's no change in the intracardiac pressure. A significant increase, filling to the left, pushing septum to the right, less filling to right side chambers. All the changes are completely opposite. More velocity on the left and the less velocity on the right, but significant flow going back into the hepatic vein, calling it diastolic flow reversal in the hepatic vein, which is characteristic for constrictive pericarditis. So those two changes were very characteristic. And then another important aspect or diagnostic feature came. This is actually from Dr. Mario Garcia when he was at the Cleveland Clinic, and show that annulus velocity, we talked about that yesterday, that the E prime velocity is the sign of health, because normal individuals, usually even the 7 years old, should have a 8-9 centimeter per second. Healthy individuals, I don't know, I haven't seen 20s, but I think it's 12, 15 would be great. But in all forms of myocardial disease, whenever the myocardium is involved, it's hypertension, ischemic, hypertrophic amyloid, whenever myocardium is involved, relaxation is reduced 100% time, so that E prime velocity is reduced. So if you look at patients with a myocardial disease with heart failure, usually E prime velocity is a 5 centimeter per second or less, okay? But in patients with constriction, it's amazing. Constriction and restriction, they are phenotypically similar. They comes with edema, shorter breath diffusion, JBP elevation. But when you look at the hemodynamics, they're completely opposite. Because in constriction, E prime velocity, because of the distic layer, the lateral motion of the heart is quite limited. So the major way to fill the ventricle is to increase longitudinal motion of the annulus or the heart. So that even in heart failure, E prime velocity is actually increased compared to the E prime velocity in myocardial disease. So this is a small study we did many years ago. It's almost 20 years ago, that amyloid and restriction, E prime velocity is usually less than 7 or 8 centimeters per second, and then constriction is more than 8 centimeters per second, almost all of them. So if, the lesson from this is that it's pretty easy that someone comes to us clinically in heart failure, JBP is about 20 or 15, and little edema, and then echo shows E prime of 10. I think that should be constriction until you've proven something different. It's almost, more than 95% of the time, that person should have constrictive pericarditis. That's how strong this E prime velocity is for diagnosing constrictive pericarditis, okay? So with all those things we've done since 1988, the Dr. Tim Welch, Terence Welch was the third-year cardiology fellow. Now he's in Dartmouth. But this is his research project. And one summer we said, well, we've seen so many constricted patients in tricuspid regurg and right heart failure. Let us look at really whether we can come up with the echocardiographic diagnostic criteria. And we look at several hundred patients. And these are the features. Interventricular dependence I told you about. Sometimes you can see that visually, but sometimes it can be quite subtle. And M-mode echocardiogram, old modality, but the inspiration go down and then expiration coming up to the RV. And then restricted mitral inflow velocity with some respiratory variations. And then E prime velocity is more than 8 centimeters per second. And then most specifically, we found that the hepatic vein Doppler flow reversal during diastole with expiration is a more specific sign that we found from the several hundred patients we saw together. And I'm showing these parameters here you can recognize in atrial fibrillation. So these parameters actually works not just in sinus rhythm, but also in patients with the atrial fibrillations there, especially the hepatic vein Doppler and E prime velocity as you see it here. And luckily, and I told you that Dr. Klein, he is really having a major leadership role in diastolic function and pericardial disease too. He was a fellow when I also stepped there with Dr. Hadley. And then luckily, he was at Cleveland, he is at Cleveland, and then he showed that our diagnostic criteria has especially the E prime velocity of 9 centimeters per second or greater has a very specific specificity there. and then sensitivity and the specificity with the 4 parameters, and then show again our impression, finding that the hepatic vein Doppler really makes the most specific diagnosis for constrictive pericarditis. With that as a background, let me just show you some typical cases and also some atypical cases. But we are finding now all the hemodynamic traditional features, equalizations and the peak pressures lower than 50, all of that really were found in patients with a very profound, advanced, pure constriction many years ago, based on like few patients. And we are finding that that's not the case now currently, and the echocardiography has been so sensitive in detecting patients with even early stage or localized constrictive pericarditis. So I'm going to just show you how we're using it clinically. And these 2 patients I'm going to showing here in the same way came to the clinic. And this patient came, I remember, from Michigan, and had the multiple extensive evaluation, including cath showing equalization of pressures, and CT showing some calcifications, and then examination findings, and textbook constrictive pericarditis. And then I'm seeing this gentleman for pericardiectomy. That's how he came for. Everyone, for us, before surgical procedure, they go through a clinic, so I'm seeing him at the pericardial clinic. And when I look at that, well, looks fine here, but when you look at echocardiogram, E prime is a 3. That's a major problem. I told you that we don't see E prime of a 3 of constriction. Even someone with a mixed disease, you should be 8, 9 centimeters per second there. So we went ahead with the strain that shows amyloid and cardiac MRI showing cardiac amyloid. So it's interesting that all the hemodynamic data of equalization described in 1946, and that time amyloid and restriction was not described. And subsequently, a lot of data showing that, amyloid and restrictive cardiomyopathy simulating hemodynamics of constriction. So a lot of overlap of traditional cardiac catheterization data there. This is the data that we haven't published yet, but Dr. Lloyd, he was a fellow who just left a couple of years ago. Look at this patients with the pericardial calcification and chest X-ray. Only 30% of them really do have constriction. All the others do not have constrictive pericarditis, even with the CT confirmation. CT confirmed the pericardial calcification and chest X-ray on about 77%. So sometimes we're calling valve and vascular calcification as a pericardial calcification. And interesting thing is that some of them, actually 18% of them, then develop constriction a few years later. So they need some follow-up, but not all pericardial calcification means constrictive pericarditis. And this is a patient a couple days later from Arkansas, and he knew, or he came to us with a diagnosis of cardiac amyloid and cardiac catheterization and the no equalization here. Wedge pressure is 23, RV diastole is 13, significant pleural effusion, and then he has some monoclonic myopathies, and all of that, some hematological problems. As he came to our cardiomyopathic clinic, but when you look at echocardiogram, his IVs is plethoric, and then E prime velocity is 20 in medial, and the lateral is a 16. And you cannot have myocardial disease. Amyloid, symptomatic amyloid, is E prime velocity is a maximum going to be 5 or 6. You cannot have 20 with any myocardial disease, right? And then strain here is very characteristic that pericardial layer is a tether to the lateral portion and then inferior portion of the myocardium, that the regional strain imaging is always reduced. Very typical here. So, and then that's why that E prime velocity laterally, which is usually higher than the medial normal settings, but it's lower, although it's very high, but it's lower than the medial E prime velocity because of tethering of the myocardium to the pericardial layers. So we call this as annulus reversus. That Dr. Taji came up with this particular name, and then it's not present in everyone, but once you see that, you should consider diagnosing constrictive pericarditis. This is a hemodynamics I told you about. This is a traditional cardiac catheterization data. When you compare that with the restriction, constriction, almost 80% overlaps. You cannot use equalization, PA systolic pressure, and then these ratios and stuff. This is, okay. So now Dr. Nishimura has done, or Dr. Talija when he was a fellow, and those two patients are almost identical in terms of the equalization of LV and RV, but in restriction, there's no discordance. It's concordant change, LV and RV pressure decreases with the inspiration, as we see that, and then increases with expiration. But in constriction, I showed you, the inspiration, LV pressure goes down, but RV pressure goes up. So you have a discordant pressure change. That's what our colleagues in the cath lab now use for diagnosing constrictive pericarditis, as well as other interventricular dependence in the pericardial disease. So let me just show you also the reason the echo lab is important, the imaging is important, is many of these patients do not come to cardiology clinic. Because of ascites, they are edema, they short of breath, they go to primary care or even pulmonary and GI clinic. And this is an example of gentlemen that significant anasarca for a whole year, an extensive evaluation. You can see that because of ascites, they did endoscopy, laparoscopy, liver biopsy, all of that. And everything was negative. Even echocardiogram was normal at home. And he was very frustrated. I remember we're seeing him in the emergency room. He drove 12 hours one evening, and then our EDCT shows significant ascites and hepatomegaly, and then patient was referred to our GI because of ascites. And our GI consultant, luckily, he looked at his neck vein first. Because they seen it many times that people come as a liver problems and ascites and turned out to be constriction and the myocardial disease. Well, look at that. I mean, just looking at the neck vein alone, right? You know, is GI consultant, and then I'm sure he went through our cardiology rotation in internal medicine, right? So he said, well, doctor, we've got to do an echocardiogram. And then after a year of all this work, and one echocardiogram shows you septal motion change, restricted marginal inflow velocity, and you can see this, you know, the strain imaging exactly the same as before, and the lateral is 14 and medial is 18. I mean, we are done. This is constrictive pericarditis, and we send him to the pericardiectomy because I don't think we need anything. Nothing else can be the diagnostic possibility with these parameters, right? Because nothing else can do that. So now we are using echocardiography as a first-line diagnostic hemodynamic methods, and then most of the times it can be quite conclusive. And then, more specifically, this patient has the hepatic vein Doppler showing the lower forward flow velocity with the expiration with a significant flow reversal back into the hepatic vein, resulting in ascites, right? And then I think it's so important for the members of echocardiography and our sonographer staff and fellows looking at hepatic vein Doppler, which has been so important. This is normal Doppler, a little bit of reversals there. And then systolic is higher than diastolic velocity, and severe TR, right? We're looking at neck veins, but this is usually, not usually, but always a systolic flow reversal V wave here, right? And then myocardial disease also has a significant diastolic flow reversals here, but completely opposite. It happens with inspiration, because it's inspiration because your forward flow velocity is higher, inspiration, and then this is expiration. So really, the hepatic vein Doppler really can separate the different pathologies very, very well. And this is an example. I am at the valve clinic, seeing this gentleman that came to us with the tricuspid valve repair. We got right heart failure, severe TR. But I always look at hepatic veins. It's my just part of the echo. And something unusual here, right? Because you have a huge reversals here. And I was looking for systolic flow reversals with a severe TR, but this gentleman has, all of them has expiratory diastolic flow reversals. And then you don't really see that many people, I mean, most of patients we see with a valve disease they also have underlying myocardial disease. I'm sure Dr. Sabi agrees with all those guidelines and things, because the AS, the mitral valve and tricuspid, all of them, they have a myocardial disease that we don't expect E prime of 12, maybe 6, 7-ish. And then this is a reversed. And this is the patient with a constriction in this, and also with the superimposed tricuspid regurgitation. So our surgeon now been kind of interested in the TR, and we found that in a large number of patients with a constrictive pericarditis, the 1/3 of our patients with the constriction do have a tricuspid valve regurg, and even mild degree of tricuspid regurg has a significant prognostic implications here. You see that? Compared to the patients with the trivial to no tricuspid valve regurg. And then I also want to show you a case that patient also developed TR, or even mitral regurgitation after pericardiectomy, because the AV, the annulus get dilated with the pericardiectomy. You see it here. So I'm trying to emphasize, we talked a lot about that yesterday evening during dinner time, that the importance of E prime velocity. I think the E prime velocity really tells us the health of the myocardium. But constriction is higher, not because of healthy myocardium, but because of the just constrictive myocardium that has to increase the annulus motion to fill the ventricle on that. So this is interesting. The late 1990. This is a patient. This is a study that we did. Many years ago, that Dr. Ha, he was a fellow with me that time, and one day he came to me and said, "Doctor, he was working on some constricted database, and this is kind of interesting because, this is Dr. Sharif Nagwe's data. I'm sure he's here, and showing that E of E prime velocity is proportional to the wedge pressure, right? E of E prime increases, right, because the E prime velocity goes down, E velocity goes up with the high filling pressure in myocardial disease. It proportionally is positively correlated here. I think this is Dr. Nagwe's data. And then he said, well, it's interesting, constriction is completely opposite. Because higher the worse the constriction, actually E prime velocity is higher, so that E over E prime velocity gets less. So it's almost opposite like this. So, but he had only 10 patients, and he said, well, can we have these 10 patients published? So Dr. Tajik said, well, probably if you come up with a good title of the paper, has some chance. So one morning, we talk about annulus, paradoxus, all of that. So one morning we came up with the name of annulus paradoxus, and this is one of, Dr. Pasha kindly mentioned that we written more than 500 papers, but this is one of only few papers. Circulation says no revision, and they just accepted all the 10 patients there with very important messages because of it's just paradoxically. But then we expanded our observation, because that was many years ago. Now, the patients with constriction is not pure constriction. It's a lot of them has a mixed disease. They have a bypass surgery, radiations. They have some other myocardial disease there. So it's interesting when you separate them out. The classic constriction is a very blue is a classic pure constriction, and the red is the one with a mixed myocardial disease, meaning radiations and bypass surgeries and other known myocardial disease. So if you look at the patients with a classic pure constriction, E prime velocities, all of them higher than 9. But in patients with a mixed disease can have less than 9 centimeters per second. And also the E of E prime is pure constriction is usually less than 7 or 8, 10. But in patients with the myocardial disease, mixed constriction has looked like a myocardial disease. So a little bit different, but because of the mixed component to it. So when we look at the prognostic value after pericardiectomy, the E prime velocity, again, is the most important part. Because if someone has a constriction, E prime velocity is more than 9 centimeters per second, meaning it's a purely constricted pericarditis, and they do well with the pericardiectomy. But if it's lower, 6, 7, 8 centimeters per second with hepatic vein Doppler showing constriction, and radiation patients, the CABG patients, are going to be big problems with the surgical procedures. So this is a kind of amazing because it happened a couple months ago. We also train our cardiac anesthesiologist and critical care, and they do intra-op echocardiogram with a cardiologist. And we got a call one day, and patients from surrounding area with an extensive evaluation, including cardiac catheterization and CT, is a constriction because of calcification and then equalization, all of that. And usually patients come to us, pericardial clinic first, and then we clear for the pericardiectomy. But this is so straightforward. Surgeons say, "Oh, come right to the." So this lady in the OR now anesthetized, and the intra-op echo is being done, and then our anesthesia colleagues, and then doing intra-op TEs. What do you think? What do you think he said to the surgeon? Looking at this. So this is probably the only case I've seen that way. The anesthesiologist kind of say, I think patient does not have a constriction. So surgeon said, why do you think that? I mean, the outside shows cath and CT shows calcium and all of that. He told the surgeon, I think E prime velocity very low. That's exactly what he said. So, okay, I mean, to surgeon, you got to stop cardiac surgery you plan for pericardiectomy from outside because the E prime velocity is low. And he said it's only 4 centimeters per second. So, and then we had a huge conference call, and then surgeon said, if that's what cardiologist said, we'll stop and then reevaluate. And he underwent other extensive evaluation, including cardiac cath. It turned out to be patients with HFpEF with no pericarditis disease. So E prime velocity is playing a significant role in diagnosing patients with a constrictive pericarditis. So this is now August. We have a kind of a very fantastic 2 papers. One from Dr. Klein. He put together international position statement for the pericardial disease, and also we have another paper from Northwestern and Cleveland us for the pericardiectomy. I'm going to show you, but this is the sort of algorithm for echo diagnosis of constriction, and was adopted from our Nature review almost 10 years ago, and looking at the plethora of IVC first, and then go to septal motion change, and then E prime velocity plays a major role. More than 8 centimeters per second is constriction, less than 6 with restriction, but mixed disease maybe even is a possible even with the 5 or 6 centimeters per second if hepatic vein Doppler shows the specific changes I showed you. But another important thing this diagram shows is that the patients with exaggerated intrathoracic pressure change, meaning obesity or COPDs, can do exactly the same Doppler findings. And so this is the other clinical conditions that can give you pulsus paradoxus and the interventricular dependence. And echocardiography looks almost identical except few variations. So if you show you this one is a patient has pericardial calcification and the septal motion is bad, but E prime velocity is only 7 and the lateral is higher, and this is more of the not restrictive mitral lymph velocity. E velocity is lower than A velocity. So you got a question that this may not be true constrictive pericarditis, right? We are looking at E velocity higher than A velocity in patients with constriction. So what's helpful is the patient's IVC is collapsing, and then patients with SVC is a huge forward flow velocity with inspiration, which does not really happen here. So this is a paper we wrote many years ago that in patients with the constriction, superior vena cava velocity, the systolic velocity does not change much at all, just stays the same because the RA pressure is high, so it doesn't really matter what happens to intrathoracic pressure. But in patients with the normal RA pressure with an increased respiratory effort with a negative pressure in the lung, you have significant flow with inspiration, and then nothing much happens with expiration. So this is, we always do the superior vena cava velocity in patients with a constrictive pericarditis, just make sure that we are not missing or we are misdiagnosing patients with a constrictive pericarditis. So because the wedge pressure changes is too much for for the heart to accommodate. So there's a main reason that the patients develop the pulsus paradoxus or interventricular dependence in patients with the COPDs. So let me just show you a few other presentations. Here is the patient, 75-year-old. I told you that initial box was the IVC plethora. I think we made a mistake, because we are seeing many patients, not a many, but a substantial portion of patients with constriction looking like this. I mean, this is huge collapse, respiratory collapse. I mean, people say this cannot have a constriction, right? High filling pressures. But this one a little distorted here. And then patient cardiac catheterization shows this is resting. RVDP is a 7, and then LVDP is a little bit high, but it's nothing much there. But patient's significant dyspnea, patient's CABG 20 years ago. And then when you do echocardiogram, it's a diagnostic for constriction. That's why we think it's a lot more sensitive with echocardiography, because the E prime is a 10 and the annulus reverses there, restricted filling, all of that, and then significant diastolic flow reversals. So what's happening? How come cath does not show constriction and this one shows it? I say, it's almost like a HFpEF patients. Resting may not show something, but you should exercise. So we ask our invasive colleagues to exercise. This is a resting I showed you with exercise. Look at that. LVDP goes almost a 40. Rapid square root sign here, and RV also goes up, but not as much as LV. This is more of the localized constriction, more affecting the left than right, and because of this significant calcification only to the left side of heart. So we are seeing a lot of, frequently we are seeing now patients with the normal JBP, little fatigue, a little short of breath, is only left side constricted pericarditis. You have to exercise. So this is also interesting because for an echocardiographer now, pulmonic regurgitation velocity, I'm sure Dr. Zagby will appreciate here, because this is a very abnormal pulmonic regurg Doppler, because it's very, very sharp. After Bentall procedure, and now having quite short of breath and paroxysmal AFib, and this is a significant TR. Tricuspid regurgitation may be able to show this one because of the significant RV diastolic pressure change and things like that. But when you look at this, interesting here is that this one, RV pulmonary regurgitation velocity comes down rapidly because this is a square root sign of the RV diastolic pressure, and then late diastole, it goes up again. You cannot go up from the RV because this is a change from the PA to the right ventricle, right? Something got to happen to the PA diastolic pressure to change that increase in diastolic pressure, right? So it's interesting now, when you look at this patient's cath, this is a normal pulmonic regurg. This is a very abnormal, very RV diastolic pressure comes up like this. You see the green? That's why this decel time is so short. But the more interesting thing is LV diastolic is much higher. So this is reflecting the LV diastolic pressure circulating all the way back to the PA diastolic pressures and end up getting this type of pressure. So even pulmonic regurgitation can tell us what's happening on the LV side because of this particular change as you're seeing. And this turned out to be a constriction because of the hepatic vein Doppler shows. Because the previous hemodynamic Doppler can be a restriction. Somebody with a myocardial disease, right? But when you come to the hepatic vein Doppler, this one tells us this is expiration, and then you have the diastolic flow reversal. That's how we used hemodynamics plus the Doppler echocardiogram. So it's not really unusual for us. I don't know how, we get a call from even the cath lab and say, well, what do you think in echocardiogram, right? So it's not always one is straight and the other. We really have to work together to come up with the correct diagnosis for the patients, because this is something that we can cure with a pericardiectomy compared to the myocardial disease on it. And then this is a complete opposite. Has a bypass surgery many years ago, but the main problem is short of breath, and then when you do saturation, it's like 80 to 85s. And septal motion change is very abnormal, so we thought patient probably do have a constrictive pericarditis. We decided to cardiac cath, and this one is medial prime is 8 centimeters per second. And when you do cardiac catheterization, resting, again, very low wedge and RA pressure. But exercise, you have a significant increase on the right side. This is more of the right side constriction than left side constriction. So the predominant problem was, why is hypoxemic? Because he does have a PFO, the right atrial pressure there, and then the patients with the right side constriction presenting to us with mainly with the desaturation, right? No left side heart failures there, and then we end up just closing the PFO, and then patient was doing fine after that. So I'm just showing you the example of the left side and the right side constriction. So I'm just going to show you how we decided to do exercise diastolic function study. It's 1990 to 1995. And she's from Trondheim, and then we visiting her, and she's showing this. I think she just took this one out of the regular bicycle and then start doing the exercise testing, and she was showing amazing data, diastolic and the valve disease and all of that. So we came back and we decided to do exercise diastology, and then, as you know, we were the first. We did that, publish our data in early 2000, and this is the subsequent correlation by Kath, by Dr. Borlaug, and then Dr. Kane in the echo lab. You show this is patients with the HFpEF. And you can see that E prime velocity is already down at 600 per second here. And then when E prime velocity is reduced in myocardial disease, nothing can change much. It stays, exercise does not change, dobutamine doesn't change. It may increase a little bit, but does not go that much at all. But because of the increased preload, you can see the significant E velocity change. You have a UA prime of I think probably went from the 11, 12 to almost 20 here. And then this is simultaneous cath and echocardiogram with exercise showing that E prime velocity, E over E prime ratio from medial, not 15, around 11 or 12 is a very sensitive or specific for the patients with the wedge pressure of a 25 millimeter mercury greater. This is a definition of the heart failure with a preserved ejection fraction. But in patients with a constriction, this is a lady with a postpartum pericardial effusion and had a pericardiocentesis a few years ago, now came with a right heart failure. And this one looks like constriction. The hepatic vein Doppler is there, but somehow the lateral is not lower than medial, and there's some atypical feature of that. So we decide to exercise this person in the echo lab. And you can see that a lot more respiratory variations, and hepatic vein Doppler reversals are huge. And then you have the medial goes up more than the lateral E prime velocities. Very, very typical. So we do sometimes non-diagnostic echo or hemodynamics in cath lab. We always do exercise testing to look at that diastolic stuff there. And this is a paper that we are writing. Dr. Lee, she is the outside physician that's doing some research with Dr. Miranda and looking at the comparison of resting and exercise hemodynamics in constriction and HFpEF. It's interesting that the resting and exercise, both RA pressure and the wedge pressure is much, much higher in patients with constriction here. I mean, one value itself may not be able to separate one or the other, but in terms of looking at the hemodynamics, I thought it kind of interesting that the constriction is a lot worse hemodynamic burden with exercise here, and especially the right atrial and wedge pressure ratio is a much higher because right side heart failure with the constriction, and then a little less with the patients with the HFpEF on that patients. And then I'm going to skip this one. And then this is now pericardiectomy paper that the Arcaz and Northwestern, along with the Cleveland and the Mayo, we put together this review paper and just published a couple months ago. And this is the surgical indication because the pericardiectomy is a standard treatment, and we don't really agree completely. I think we. Whenever we diagnose constrictive pericarditis, even patients with the New York Heart Association Class 2, we may offer pericardiectomy because pericardiac constriction continues to progress, and once it involves the myocardium, it's a big problem too, and becomes a calcified, and is kind of a problem. So this is a consensus, but our practice is a little bit different in that we probably do a little bit earlier than the later in this patient population. So let me just show you this Dr. Sheff, who is a master surgeon doing pericardiectomy, and this is a thick pericardial layer, but not calcified. You can see that the heart tried to bulge. Okay, and then this is a calcified pericardium. Look at, it's a lot more difficult, and then he really has to come up with all the interesting tools to get all the calcifications undone. So the pericardiectomy is a standard procedure for the patients with the constriction for us, and then this is our data of a survival after pericardiectomy. The patients with the radiation does worst, and post-op is second worst, and then patients with idiopathic, meaning most of them related to the viral pericarditis, they do pretty good with the pericardiectomy. So radiation continues to be a problem. So we evaluate that very carefully whether patient will survive after pericardiectomy in it. And then another interesting observation we have is that this patient has a constriction of this big fibrotic mass in the AB group. Here with the same thing, and then this is the intraoperative photo, and we always do the intra-TE, as you probably do, and then here the RB does not move much, and now is freely mobile after pericardiectomy, and there's a trivial degree of tricuspid regurgitation, and becomes a mild, and we decided probably it's okay to leave that. And then patients having pre-dismissal TTE showing severe tricuspid regurg. So we are seeing not infrequently worsening of TR and sometimes mitral valve regurg. So whenever we see the more than mild, even mild degree of TR and MR, we are considering, we are very careful, moderate or greater, no question, we're going to repair the procedure. But even mild, our surgeons are quite concerned that they may develop significant constrictive pericarditis. So this is our hemodynamic cath data. The pericardiectomy was the first surgical procedure at Mayo in 1935, and until 1990s, still average cases 5, 6. And something happened in the 1990s, and now we're doing 60 to 100 pericardiectomies a year. And we just want to take a little credit, Echocardiography lab, because 1994 was the one that we published paper. And I think the echocardiogram, actually constrictions are diagnosed most of times, even de novo, without any clinical suspicions of constriction in the echocardiography laboratory. And then I showed you before that now only 15% of patients with the pericardiectomy undergo cardiac catheterization. Let me just do just couple more slides, and then transient and effusive constriction, and then patients with significant problems with acute pericarditis, and then comes into us, and then this is the cardiac MRI. We always do cardiac MRI with the constriction because of the tissue characterization, and then we treat with NSAID. And you can see that here, because of the marked inflammation, and these patients really improved after the medical therapy. So before considering pericardiectomy, if a cardiac MRI really shows the significant inflammation, we try medical therapy first and then proceed from that. And this is data that Dr. Klein put together and how to objectively classify the delayed enhancement there. And I'm going to just show you the thickness and the extent, and then a number of slices is what we have. And this is a paper that we put together. When you see the significant inflammation, we do NSAID, steroid, and colchicine therapy, and they get much, much better in most of the times before consideration of pericardiectomy, as you see it. And this is the one that most impressive to me, that the patient has the 8 millimeter pericardial thickness, and a lot of inflammation, cardiac MRI, and steroid for the 1 week. And you see that so much dynamic changes of 8 millimeter to 2 millimeter with no pleural effusion, right? So this thing can change so quickly, and then medical therapy can really work on it. Let me just skip through that, and maybe important to. I was trying to show you the also the patients with significant pericardial effusion after post-pericardicentesis. You can develop significant effusive constrictive pericarditis, and also with the cardiac MRI showing inflammation. Then we do medical therapy, and most of the times we can try to do that. So let me. I think it's important to. We can do some Q&As. I was trying to show you for the last 50 minutes or so. I think the cardiac imaging really plays a major role. I mean, many other diseases the same way, but especially for the pericardial disease, the echocardiogram, cardiac MRI, and CT, even the PET we didn't talk about today, though. And in terms of diagnosis and also the management. And I think the echocardiogram hemodynamics has been very sensitive, and we are picking up now early an atypical constrictive pericarditis and localized ones. And then the standard therapy is pericardiectomy, but you can also try the medical therapy when you see the significant pericardial inflammation. And I didn't have time to talk about the AI, but we have a significant role, a promising role for the AI for future in diagnosing and managing patients with constrictive pericarditis. Thank you very much for listening. Thank you.
Well, thank you so much, Dr. O, for a masterful talk spanning all imaging modalities from chest X-rays to MRIs to echo, but also sharing with us your wisdom and thoughts. And we're going to open the floor for questions.
Jay, thank you for coming and sharing your experience and wisdom over the years. And I think, you and many of your colleagues and trainees also have contributed so much to this field. I have two questions for you. I think obviously in the extremes, it's very easy to diagnose. And the question I have are two things that you showed us. One is the low pressure or low, the atypical features where you have lower pressure in diastole and the IVC is not as impressive, and yet you have constriction. How do you handle that? Is there a role for fluid loading? So conceivably these individuals are diuresed or something like this. And the other is, how do you address mixed disease? Once you have mixed disease, it becomes much more complicated. And is the role then of CT, MR much more contributory to the diagnosis as opposed to management?
Yeah. We actually, one of our young staff is writing the discrepant cath hemodynamics and echocardiography and clinical presentation echocardiography, because we are now seeing, not a lot, but we have enough cases from the cath lab, hemodynamics say no constriction, but the echo shows constriction and turned out to be constrictive pericarditis by pericardiectomies. So I'm convinced, doing this many, many years, that the echocardiogram hemodynamic is a lot more sensitive hemodynamically than cardiac catheterization. Even the low pressure settings, all those changes shows up in echocardiograms there. So it's a little uncomfortable because we have a very good discussion. We have many cases that, surgeon and then hemodynamicist and then echocardiogram, primary care physicians, we have to just discuss what that really is. And then we getting a little more convinced that if echocardiography shows and patient is symptomatic, we even had the patients with just fatigue. Not a whole lot of any other things there, just fatigue with the echocardiogram, just constriction, and the pressure was not that high, but the TBI was a little low and the stroke volume was a little bit low. And then patients so grateful that we did pericardiectomy there. So it's a huge discussion about that. And in terms of myocardial disease, it's really hard. I think we can do strain imaging, we can do cardiac MRI, we do other studies, but unless patient has radiation, that particular patient with significant heart failure there, unless you do pericardiectomy, patient is not going to improve because it's going to be chronic progressive disease there. So with that knowledge, we have to discuss a lot with the patients, but we end up doing pericardiectomies. But I'm not sure how much of we don't have the data that if you have delayed enhancement of this percentage, we cannot do the procedure because of your high risk and things like that. But it's going to be just case by case at the time. But you're exactly right that we should have more of objective data to separate the worst prognostic patients and other prognostic patients. Yeah. Yes. Thank you.
You're very active. Thank you for your thought. As always, masterful. Getting back to Bill's question on fluid challenge, it's interesting. When you and Bill were still training, back in the late 70s, early 80s, there was a paper that came out talking about occult constriction.
Occult constriction.
And I remember a couple of patients that I actually was able to show that these were people that had symptoms suggestive of. We only had the cath lab. This is way before. We was EDMOR echo and the beginning of 2D and no Doppler. And the trick was to fluid challenge them. And when you challenge them with fluid, then you got all the hemodynamic findings of constriction. Mm-hmm. And I actually had a couple of patients that I was able to show that. Dr. DeBakey went ahead and got rid of the pericardium. He had pericardial thickness in the OR, and patients got better. And I actually accumulated a few brownie points with Dr. DeBakey back in those days. So going back to Bill's question, is there still a role for that, for occasionally doing fluid challenge? Because I tell you, those couple of anecdotal patients were very, very, how you call it, very impressive. Yeah. And of course, we didn't have any of the other methods we have now. It would have been wonderful to have done it with everything else we have today. But,
thank you for the question, Dr. Quinones. I really, Miguel, he's been a fantastic teacher, not just to you guys, to me too, and so many other echocardiographers, and really appreciate all the teachings that you had and all the encouragements. You talk about the fluid challenge. There was a paper that from Ohio State in 1976 that Dr. Charles Bush did put together in 11 patients again. So I think you're exactly right. I mean, that particular situation, and someone echo shows like constrictive pericarditis and the wedge pressure is at 11, 12, and air pressure 5 or 10. I think they'll exaggerate the response with the fluid challenge. But now we are doing more of exercise testing because that's more physiologic. There's shorter breath there. So you can do either, but I think it all depends on who does invasive hemodynamics there. And the younger person who done echocardiogram together with us, they do more echocardiogram exercise. But the others with the traditional training, and they do fluid challenge, and both of them will bring out with the constrictive pericarditis hemodynamics. But what I am trying to tell you still is that the echo hemodynamics is incredible, that even the pressure of a 5, 10 of the wedge and the right atrial pressure with the constrictive pericarditis, it really shows in echocardiography, showing the 4 parameters I showed you there. So, yeah. Yes, Steve.
Okay, thanks for coming again. Thanks for sharing your expertise as always. Couple questions. So you started the showcase, and then I think you had to go through it, but the post-op scenario. So post-sternotomy, post-pericardiotomy, what diagnostic criteria do you use, change, emphasize in that scenario? And how fast does constriction really happen after a sternotomy? Because sometimes our fellows will see the septal shift, they'll see the IVC plethora, they'll call it on day 3, and we say, no, it takes time. But how long does it really take? It's not hours, it's not days, but is it months and years? And what's sort of the average real constriction after surgery? Sure.
With Steve Little as the past president of ASC, I'm going to show you. This is I mentioned Dr. Liv Hadley before, and she unfortunately she passed away a month after I saw her in May 23, and she was living in Spain. And I remember that she was honored at the ASC in 2022, and all the Methodist friends sitting with Liv Hadley table there. Back to your question, I think we did a study. I didn't show you here, but Dr. Miranda did the study of cardiac surgical patients. Soon after that, we did echocardiogram about 200-300 patients, and then 20% of them developed transient constriction in terms of Doppler echocardiogram. So echocardiography shows the hemodynamics of constriction like 1 or 2 or 3 days after the cardiac surgical procedure. So we do all of them, the Doppler echocardiogram for the constriction for the cardiac surgical procedures. And Dr. Begamary, one of the cardiac surgeons, actually giving the colchicines to all of his patients for cardiac surgery to prevent the post-cardiotomy syndrome. Because yes, we know that it happens about 20-30% of them that comes back with some chest pain or pleural effusions, but many of them will probably resolve spontaneously, but we don't really know who's going to develop constriction later on. And we had the protocol trial to randomize patients after cardiac surgery for the colchicine versus no colchicine for follow-up for 1 year. We couldn't do good follow-up, and we ended up not doing it. So I think that particular trial should be done because it's I think there's a lot of benefit. The European Society colleague Imazio, he showed that not the post-pericardiectomy, but the atrial fibrillation incidence was much less after cardiac surgery if you give colchicine for a month or two. So there's some benefit of that, but we don't have any big trial to show that. Yeah. We should. I think we should do it together, maybe.
Final question from Dr. Jared Lowry, our cardiac surgeon.
Oh, yes. Oh.
Oh, thank you.
Yes.
I did have a question regarding the role of the morphology of pericardium in patients in the diagnosis skill set. I think your absolute accuracy is 90%. There's a certain small group of people whom we find we're being asked to operate. Sorry, just asking about the morphology of the pericardium as shown on CT or MRI in these gray zone areas. As Dr. Zogby said, the extremes, and you've indicated, very simple, but the group we mostly get referred these days are people who've had previous surgery, who have cardiomyopathy and so on. And as surgeons, our perspective is we're pretty reluctant to operate on someone who's got a relatively normal-looking pericardium on the CT or MRI. But do you have any data showing actually what the prognostic value of the thickness of the pericardium is, for example, whether it's 1 or 2 millimeters or 3 or 4 millimeters?
Can you go to next? Yeah.
Are we really missing the boat here in turning down people for pericardiectomy who appear to have a normal pericardium on our imaging studies?
Yes. We written paper many years ago that the patients who underwent pericardiectomy, actually the pathology and then again fellow, they look at the pericardial thickness. Because what happened was that we have many patients that came from elsewhere. The cath shows constriction, echo shows constriction. They do CT, and the pericardial layer is normal, and then our surgical colleagues are a little reluctant to operate. But we, based on our diagnosis on hemodynamics, and then we did surgical procedure, and then actually the 20% of them, 18% of them has normal pericardial thickness on the constrictive pericarditis there. So especially the post-surgical patients and the radiation patients, their pericardial thickness is not as thick as the patients with the pericarditis or some other disease, rheumatological disease. They have a thick pericardial layers, but the patients with the cardiac surgery and radiations, relatively normal pericardial thickness. So that's why we don't usually do the CT routinely once we have a diagnosis of echo. Hemodynamically constriction, then we do cardiac MRI, just make sure that with the inflammations that we can treat medically. And CT, we do that someone with the previous bypass surgeries or we about 10% of our pericardiectomy was a redo pericardiectomy because they did the partial pericardiectomy from phrenic to phrenic nerve. They come back to us with a recurrent constrictive pericarditis because we didn't do the diaphragmatic and posterior. All of the complete radical pericardiectomy is not done. So in that particular case, we have to do the CT to look at all the structures and stuff like that. But you're exactly right. I think there's a lot of reluctance when the pericardium. Traditional feature of a constriction is a thick pericardial layer there. But this is data we show that in the pathology, this is a patient who had a constriction hemodynamically, and the pathology showing the 18% of them has a normal pericardial thickness. So,
Thank you very much.
Yeah, sure. Yeah. Oh, Sharif. Thank you, Sharif.
You were going to get into it if you with pericarditis.
Yeah.
If you can take us through your diagnostic approach and management to these cases.
Okay.
So the question was effusive, constrictive, diagnostic approach and management.
Yeah, I think the effusive constriction, I just didn't have. So again, we are now seeing many of them, many procedures. I mean, this is patients with TAVR and then PPM, the pacemakers, and end up having tamponade here. It's a blood effusion. And then patient came back a couple months later, even feeling worse. So you can see that this is a thickened tethered pericardial layer there. So patient developed this post-pericardicentesis effusive constriction, and then Doppler showing this, and then this is resolution of the medical therapy. And then this is another patient with a tamponade and pericardicentesis, and then this is a post-pericardicentesis showing the significant constriction here. So what we do here is we still do cardiac MRI, but the most of them with the pericardicentesis, we know they, the pericardial layer will be inflamed anyway, but we like to see the extent of it. And this is an initial description from Stanford many years ago, but this is our data. And then after the pericardicentesis, we have almost 20% of them by echocardiographically, they have a constrictive pericarditis. So we have effusive constriction, more frequent with blood effusion, and more patients with the E prime velocity higher. And then, so for now, in everyone we do pericardicentesis, there are potential for developing effusive constriction. We are treating with the colchicine at least 1 month. If someone has echo Doppler features of constriction, after pericardicentesis, we're going to add the NSAID and colchicine in 1 and 3 months, just to make sure that we don't develop the effusive constriction. And then here, still, a couple of them develop a significant constriction that we have to do pericardiectomy after that if you don't do that. So this is an interesting paper that Dr. Miranda published, because when you have large effusion and pure tamponade versus patients with effusive constriction has a different mitral inflow velocities, because tamponade patients, actually Doppler is more of the grade 1 diastolic function stuff, because you have the delay of filling from the early diastole, so E velocity is very small and then A velocity high. This is a typical pure tamponade. But if someone has effusive constriction, large fluid, they actually have a higher E velocity than low E prime velocities there. So this sort of tells us that after pericardicentesis, even before pericardicentesis, if you show this, it's to be higher chance of developing constriction, effusive constriction. So we end up being a little bit more aggressive. Probably going to give you a colchicine for 1 month here, but this will be NSAID for 1 month and colchicine for 3 months. That's how we trying to prevent effusive constrictive pericarditis in these patients. Is that okay? Yep.
All right. Okay. Well, thank you so much, everyone, for joining, and thank you, Dr. O, for coming after 15 years at Methodist, and we'll see you guys next week.